Hello and welcome to Point of View Podcast, a series of conversations from Kaufman Hall and Associates about the challenges and opportunities now facing hospitals and health systems. Under the current fee-for-service model in healthcare, hospitals and health systems often play an all-things-to-all-people role in the communities they serve. But this approach will likely change. Under the new fee-for-value business model, providers will be paid for managing the health of a patient population. Very different types of providers that play different roles will emerge. To explain this transition, we sit down with Jim Pizzo, Managing Director and Head of the Physician Strategy Practice at Kaufman Hall and Associates. Jim Pizzo, what do you mean when you say that currently hospitals and health systems are playing the role of all things to all people?
When a patient wants care, they go to their physician, and their physician or their health system will effectively try to provide them with whatever care that the patient desires or that the physician thinks is appropriate. And in that role, that physician can refer that patient to any one of a number of different facilities within the health system, outside of the health system, but it tends to be a fairly disjointed approach towards treating a patient and finding out what their real needs are versus putting them through whatever tests they desire or the physicians determine are appropriate. So you may have duplicative tests ordered as the patient bounces between physicians. You may have procedures that are done that the information is not shared between one physician and another or between the health system and the physician. And what you get is a patient that bounces around through the health system and sometimes gets extra care or sometimes not even the level of care necessary. In general, it's a way of giving care that is reactive. It's each physician or each member of the health system saying, what can I do to address the problem of the patient at this point in time? And that doesn't always assure that the best treatment or the best approach towards care is taken.
Why and how will this change under the value-based business model?
The type of care is going to switch to a much more proactive manner and method of care, where the population as a whole is reviewed and each of the patients who present under different scenarios and with different ailments will be treated in the same fashion or the same manner, because the patient's outcomes can be measured and can be improved by following guidelines and protocols, and the health system will be better able to control the overall costs in which the care is provided. So the focus will go from being reactive and being paid for multiple services that you're allowed to submit for reimbursement versus being paid a single payment for the provision of all the care related to those individuals in the future.
Is this going to change the landscape for providers?
I definitely think it's going to change the way providers look in the future. I think the lines between providers, health plans, and other components of the health delivery system, such as post-acute and ambulatory, are going to begin to blur. To truly treat the comprehensive needs of the patients and the populations they're part of are going to require health systems to be able to manage the health and provide the breadth of services across specialties and settings from post-acute to acute to ambulatory. It will also require them to serve the patient populations on a geographic manner to cover the markets that they serve.
What are the different types of providers that will emerge?
In the future, I think you'll see three broad classifications of providers. The first will be the population health managers. Those will be the large regional health systems who are going to be able to build out the networks, to develop the capabilities, and to capitalize the activities to serve the population as a whole. They will integrate many other smaller providers, but they are going to begin to appear to the public as much a health plan as they are a provider. The next broad classification are the major participants. And these are the healthcare organizations that have established their brand in the local markets and who are known for quality and who serve the communities that they're located in. However, many of these major participants won't have the capital nor the geographic scope or the scale necessary to be a population health manager. The third broad classification is the contracted providers. Contracted providers are basically going to be provider organizations that provide a service for a fee and are measured based upon both their quality and their cost. And these are effectively going to be the price takers in the future. There will be a role for these providers, but it will be a much more limited role, and effectively they will have to continually be competing based upon value, and value can always be determined as a function of price versus quality. So they are going to live in a market where they will be a price taker and will not be contracting typically directly with the payers or the employers, but typically through a much larger organization.
How do hospitals go about understanding and deciding which one of those providers they want or are able to be?
Well, I think it's going to be a two-way process. First will be what they want to be. Second is the role the market's going to determine that they're going to fulfill. So to become a population health manager requires a lot of capital. It requires scale, and it requires new capabilities and functionality that currently don't exist. So even with the proper level of capital and the proper scale, the challenge will be, can they transform themselves and build out these capabilities that hadn't been there in the past? Some will make it, some will not. The role that those who don't make it may be to become a major participant within the market. Those who have chosen a strategy of being a major participant in the market will have to continually assure the market that they provide high-quality services at a reasonable cost. But they will have a niche because patients and other segments of the provider market are going to look to them for those services within their market. Many times these may be the standalone marquee hospitals that have a quality image and a quality reputation but are just not part of a network. The third is many people may not seek to be a contracted provider. However, if you can't manage population health and if you don't have the marquee image in the local community, you may not be able to be that major participant, and you may by default fall back into the contracted provider.
How crucial is this decision, choosing which type of provider to be?
Currently, I think there is time to evolve into one of the three broad classifications. However, if you make the wrong decision or if you pursue an option and you aren't able to deliver upon value and aren't able to evolve into a population health manager or a major participant, you may have used all the capital that you have available, in which case it leaves you with very few options in the future other than to potentially join a larger system or become a contracted provider. So we have a couple of risks we're looking at. One is timing, and the other is capital. And if you can balance those two while you build your capabilities over time, you should do fine.
The largest provider type, population health managers, what are some key prerequisites for being a population health manager?
I think there's quite a few of them. The first is that you have to have broad and deep service offerings. So you have to cover all of the different service lines, and you have to cover the health needs from purely ambulatory through acute through post-acute. You also have to manage pharmacy costs. And then you have to cover your geography, so you have to have broad and deep service offerings. Second is you've got to have relevant scale. And you have to have relevant scale for a number of reasons. First is payers and employers really only want to deal with organizations that can manage a significant segment of their population. It's too difficult to manage 30 health providers versus 3 big health providers, so they're looking for scale. The third area is technology, and everyone seeks perfection in technology, but if you wait until you have perfect technology, in many markets that means the market will have passed you by. People are beginning to make significant progress without perfect technology in place. Another thing that relates to technology, and the fourth point, is effective data management and reporting. Health systems have invested heavily in clinical technologies in recent years, and so far what they're getting is a lot of data but not a lot of good information. To manage health in the future, we'll have to have that clinical data, and we'll have to have it summarized so it gives us good information for which to base our decisions upon. Another is risk management, and risk management, again, is really the realm of what traditionally was done by the health plans. But as a population health manager with a fixed or a limited source of revenue coming in and the entire needs of the population you're serving, their health needs contingent upon being provided within a fixed payment stream, you're going to have to learn how to manage risk and provide for your patients in a prospective fashion that will reduce your ultimate costs through better upfront quality, through establishment of programs such as medical homes and other non-traditional provider activities. Leadership. Leadership cannot be overstated. The level of transformation the industry is about to undergo is tremendous. And to accomplish that, it's going to require leaders in the physician arena, in the hospital arena, in the ambulatory and post-acute arena to step up and be willing to address and change the way they do things currently. Status quo will no longer do, so leadership is going to have to be willing to take risks and put themselves out there.
What is the timeline for this transformation?
This isn't the type of project where in 3 to 5 years we'll be able to say we're finished. We can declare success and we now can manage population health. I think that based upon the pressures and the changes confronting our industry, this is going to be something where we're going to have to accept the fact that change is going to be part of all of our professional lives for a long period of time. And to be successful, I think you've got to start on it now, and you have to start small, and you have to build momentum. And part of building momentum is making sure you build in some early successes.
That was Jim Pizzo, Managing Director at Kaufman Hall & Associates and head of the Physician Strategy Practice. To hear more in this series, Point of View Podcasts, visit us online at www.kaufmanhall.com.